Hello everyone, it's good to see you back in about a month since our last meeting on this online course. So I hope all of you are doing a little better than last month and I hope things are getting better with COVID-19 and everything. So last time we talked about minimally invasive implant placement, and I just wanted to bring this issue of placing implants in any other cases regarding the maxillary anterior area, because we always want to, of course we always want to do minimally invasive surgeries, but that is not always the case when the patient's condition doesn't allow those kind of implant placement. So today I'm going to talk about some of the strategies to restore anterior area with dental implants when we have a bit of challenging clinical condition. Okay, so before we jump into the presentation, I just wanted to briefly talk about the implant placement overall, which are mostly I believe, prosthetically driven. So at the end of the day, we're placing implants according to where the teeth are supposed to be, and that naturally comes down to a matter of where the prostheses are supposed to be. So I believe the implants are supposed to be placed according to the prosthetic. So yeah, so for example, I think most of the cases, I think we all agree that screw retained restoration are more favorable because it allows you to so it has better, I would say, maintenance compared to the cement retained restoration. So yeah, I think most people would prefer screw retained restoration over cement retained. And so for the anterior area, you want those screw access holes to come out of the cingulum, and for the posterior area, yeah, you want it to come out from the central fossa. But always there's some of the anatomical limit. So even if you want your implant holes to come out of where it's supposed to, but it just doesn't, it's just not possible all the time because of the anatomical limit. So we always have ideal prosthesis in mind, but sometimes you have to compromise because of the anatomical limit. So for example, let's get the positioning of implant for maxillary central incisors in this condition, right? So as I just talked about, we want our screw hole to come out of the cingulum. So your implant kind of has to go into the bone, but like a lot of times when you have this kind of situation where you want to place your implant on the maxillary anterior area, well, the bone angulation just doesn't allow the path of the implant to go in like this. So what you end up having is like you're going to end up kind of like having exposed apical area of the implant like this. So what you want to do is, what I want to do personally is that I would still go for like this kind of position, because your implant is going to last in your patient's mouth for decades, and just because it's easier to place your implant according to where the patient's bone is, doesn't mean that the prosthesis, whatever prosthesis you put in the patient's mouth, is favorable for the patient. So I would, in this kind of situation, I would graft this area and make your situation a little more favorable to the prosthesis. So by doing GBR, I would kind of like recreate the site to be able to put my restoration favorable for the prosthesis. So you can think of some of the strategies regarding like some of the compromised area. Okay, so well, just like we talked about last time, we always can consider immediate implant placement to minimize the resorption of the bone, for example, or the recession of the soft tissue, something like that. But it's just not always the case because even if you want to place your immediate implant, a lot of times patients don't have bone and you're going to end up needing GBRs and stuff. So GBR is always, I think, key factor when placing implants in the anterior area, because most of the time you lack of bone, your patient lack of bone at that site. Another option you can think of is orthodontics. We're going to talk about some of the cases along the presentation. And of course, pink porcelain is another option. You just cannot restore, let's say, papilla under certain circumstances. And well, I think like it's not like end of the world that you don't have a nice papilla, like natural papilla, soft tissue, because if the prosthesis is hygienically made and it's maintainable, I think it's even better to have pink porcelain, nice papilla-shaped pink porcelain, than to have a really big black triangle with a very long clinical crown. So it's another really good option, and I'm going to show you some of my cases along this presentation. So this is my first case. I just brought this case to show you some of my mistakes. I'll be honest with you. I'm not perfect at all. I do make mistakes. I learn from my mistakes, and this is one of the cases where I learned a lot from my mistakes. So I just wanted to share my experience of, like lack of strategy, lack of thinking ahead, something like that. So patient comes in her late 20s, a very good-looking young lady. She came in and she said, "I just want to have all my teeth back." I said, "What does that mean?" She said, "As I was young, I lost 2 of my front teeth and 1 of my canine." I don't remember if she said canine, but and then the dentist just put her this long 6-unit FPD. I asked her, like, why did he do this? Why? And then she said, I had a little bit of crooked teeth, and then the dentist just said, okay, we can just take them out, make a bridge, everything nice, everything's gonna look nice. But she had such a big trauma after that. So like ever since her childhood, all she wanted to have is like, I want my teeth back. So by saying like a tooth back, she meant that she wanted implant on every single tooth. So I was thinking like, okay, 2 implants right adjacent to each other is going to be a challenge. Okay, and then as you look at here, there's a marked recession on number 22 area. So I mean, I thought I already knew this was going to be a challenge, but I just took the bullet and okay, let's do this. I'll try my best, and we can make this happen. So I scanned the patient's mouth intraorally, and then I just want to place the implant in a very accurate position. So what we did was I tried to do the guided implant surgery. So as you look at here, the implant, so the technician just designed this implant to go in right in the middle of the bone. Okay, so as a result, see where the screw hole is coming out of, because the patient's maxilla is like this. Okay, there's no way around. When I first sent my scan, the technician just naturally thought that, okay, there's no room for the implant to go in. So, well, I'm just gonna put the implant in the middle of the bone, and then, well, that's so much we can do. But I wanted my implants to come out of the cingulum area for the sake of the prosthesis. So, and I told the technician to kind of like shift or tilt the implant position. And I said, I don't care if the apex of the implant comes out of the bone or not. I just can, add a little bone, then that's gonna work that way. So this is how I plan the implant position. And this is how I planned also the immediate restoration after implant placement. So yeah, this tells you how hard it is to place the implant in the right position. Just a little joke. So this is what I prepared for this case. We went in, marked the implant position, made an incision, did guided surgery and everything. Implants went in, and this is how I opened the flap. So as you look at here, as we planned the implant, the apex just came out of the alveolar bone, and I didn't really get surprised or anything, because I knew the implants were going to come out of this way. The problem was, however, the amount of flap that I raised looked like this gigantic flap, right? I was so brave, I think, that I just went in. Okay, I'm just going to GBR the heck out of it, and then I added a lot of bone, sutured, and I thought, oh, I'm the best surgeon or whatever in the field, but yeah, I didn't really know, or I think I knew, but I was too optimistic, I would say, to do this kind of brave surgery, because you'll see what's gonna happen next time. Okay, so this is after 2 weeks, I think, on the stitch out appointment. Everything looked nice, except the patient started complaining about, oh, doctor, there's some metal showing up beneath the provisional restoration. And I said, oh, okay, well, that's part of the healing process. And we can make these two longer, and then it's going to cover the healing abutment, etc. However, when we try to connect those provisional restoration on the implant, so this was initially part of a pont. So these two were Pontics let's go back a little bit. Yeah, so these two were Pontics before we for the waiting period before the number 11 and 21 got osseointegrated, and then after I thought those two were osseointegrated, I switched these two Pontic area, so I connected directly to the implant, right? So these two are screw retained provisional restoration on implants. Also, you can hear the canine area, it's also screw retained provisional restoration. Well, the patient tells me that, okay, doctor, well, we don't see the metal part anymore because those two were covered by resin here. But you know, like there's still we're lacking papilla, and then we're having even more recession on the lateral incisors. And the patient keeps telling me that, oh, doctor, my teeth are getting longer, and I don't like that. I'm like, okay, so I could see this coming. So, well, what I do, and I really regret not telling the patient before everything happened, was that I should have done this, the orthodontics, even before we went in for the surgery, right? Because we all knew that for the first place, the patient had recession on lateral incisors, and after raising that big of a flap, this was kind of like meant to come as a result. So that was like really my bad judgment. I'm kind of like confessing, but yeah. So after 10 months of orthodontics, the gingival line got a little better, but still we don't really have nice looking papilla between number 11 and 21. So I would say it's a really, really big challenge to create a nice looking papilla in between adjacent implants right next to each other. So like you have to consider all those risk factors before you jump in and open that big flap. Okay, so, and at this stage I thought, okay, I would try zirconia abutment before we go to the final restoration and just see how the emergence profile gets a little better. If it doesn't, the last thing we can do is just use pink porcelain, okay? Well, the good thing about zirconia abutment, as you can see on the photo here, is that look at the surface here, okay? Compare those two surfaces between titanium and zirconia and see how shiny and really, really smooth the zirconia surface is. So as you all know, a highly polished zirconia surface is the most dense and most smooth surface of all the materials in the field of dentistry. So, and I think your soft tissue, your patient's soft tissue likes that smooth surface, okay? So after putting in the zirconia abutments and some of the, I just try to put PMMA provisional restoration on top of it, okay? And finally, after waiting a couple weeks, I think we waited for 2 weeks, we went ahead, placed the Emax crowns on it, and this is how I got the papilla for the final result. So, I mean, it's not perfect, far from being perfect, but at least it got better than the provisional restoration. So what I think is the cold cure acrylic provisional restoration, the surface of it is very porous and the soft tissue doesn't like it. But zirconia, with the zirconia surface, we kind of like gained the soft tissue back. So this is how we started, and this is how we ended. Well, the patient was at least happy. So after, it took me honestly about like a year and a half from start to finish. So it was a long journey with a lot of up and downs, but we kind of managed the case to end like this. But I would never do this again, and you know why I wouldn't, okay? So this case is also another orthodontic case. Patient comes in, she came in with a long front tooth right here, 11. That's why she came in, okay? Well, the perio was really, really compromised. the only thing we could do was to just extract it. But as you can see, the bone level of at the distal of number 11 was really, really low. And gaining, look at the marginal bone level of on the mesial aspect of number 12. It's also very low. So if you were to go ahead and place implant, that kind of condition, you'll end up having a really, really long clinical crown with the recession. So it's going to look bad for sure. So I just didn't want that. And after having those kind of experience with like massive GBRs and all that, I just wanted to avoid those kind of situations. Well, look at this. As you look at the CT, it's just hopeless, you know. Like no other word can describe this patient's condition than hopeless. So what I did was, okay, so worst case, we're just going to take it out. Massive GBR. Worst case, pink porcelain, okay? But at least I just wanted to try this. So I did endodontics because I was going to orthodontically, passively, I was going to do the orthodontic eruption, okay? So as you can see, I kept grinding the crown of number 11, and look at the gingival level of this, okay? Compared to number 21, my number 11 now is apically about 2 millimeters lower than number 21. So this is really favorable, right? For implant placement. And as you can compare these two, now you can see there was periradicular radiolucency, but now you don't have it, right? So the endodontics, I think, somehow worked out well, so was good. And you can compare how much we gained from anterior nasal spine to the peak of the bone. And we did gain like about 2 millimeters of bone height, which was great without any surgery. So this is on the day of implant placement, extracted with a minimally invasive fashion with using periotome, immediate implant placement. Also, for this case, we did immediate provisional restorations because we had such a good initial stability. So added a little bone right there. Fabricated immediate provisional. So it's interesting to see how we had like an immediate recession after placing implant. So I needed that 2 millimeter of soft tissue height for to be prepared for this recession, and really worked out well. So day of surgery, this is the very next day. See how well the soft tissue was healed in one day, right? So patient was really happy about her smile with the provisional, and then we measured the ISQ value, went ahead, finished the case. So yeah, from here to here. I think this also took about a year, this case, but was really worth waiting. The patient didn't really suffer from any kind of like big surgeries, but ended up having that beautiful smile. Okay, so another case, this is not orthodontic case. The patient comes in, she had discomfort on her all upper maxillary incisors. All of those teeth had previously treated with cast post, and I think those were parapost or something like that. But all of them had periradicular ptosis, as you can see from the CT scan. So what we decided to do was to take them all out, place implants on number 12 and 22 and make a 4-unit FPD. But I just wanted to stage this because I didn't want her to wear a flipper, like remove interim RPD on her front teeth. So this was kind of like strategic staging of extraction. So what I did was, so I used also the socket shield technique to place implant on number 12 and 22. I just wanted to keep these two to hold the provisional restoration. Okay. So I also did guided surgery for this case. This is a short video of how I did with those socket shield technique. So I think I showed you this last time. I'm just going to kind of skip this. Okay. All right, so place the implant. Oh, hold on. Let me go back a little bit. All right, so the photo that I wanted to show you was post-op, but yeah, I just used composite cap technique that I mentioned last time. This is post-op, I think 2 weeks or something. So provisional restorations were supported by number 11 and 21, and 12 and 22 were just cantilever. Well, the problem was this, okay? So the patient comes in, oh, I have discomfort on this area. I was like, okay, so what I tried to do was just to like put everything in a minimally invasive fashion, but it just didn't work out this time. So what I did was I had to take out the implant because number 21 failed, and I cleaned the site, everything, removed the graft material and everything. Still had kind of like okay stability there. And I GBR'd, placed the collagen membrane and sutured. So this time, so the good thing was the number 12 implant was already had like good ISQ value. So what I did was I used these two and then cantilevered those two. Okay, so cantilevered 21 and 22 for provisional. I waited a couple more weeks and then took out number 11, grafted the socket, and then yeah, by this time number 22 was also osseointegrated. And this is what we got, and this is the final. Okay, so what I wanted to tell you about this case was that what I personally try to do is I always try to do my surgery in a minimally invasive fashion. It does fail sometime, but still, the patient didn't suffer that much because I never opened a huge flap, but still I was able to manage the bone resorption with kind of, I didn't really describe it for this case, but what I did was I did kind of like envelope flap, so through and through the sulcus. But yeah, I think that's kind of enough to treat these kind of cases rather than opening a whole flap, okay? And the patient was happy because she never really went through a big pain. Yeah, so the papilla, I did kind of like lose a little bit, I would say, compared to what I had. but I think I would, yeah, I think I would say this is good enough. Okay, so another case. So those kind of cases that I showed you didn't have really marked bone resorption, but look at this case. So patient comes in, late 30s, mid 30s, gentleman. He had some accident, and then he lost number 11 and 23. And then, as you can see, there's like marked bone resorption on the buccal aspect of number 11 and 23. If you look at the CT scan, because of the fractured, I think the maxillary, the buccal bone was kind of fractured with the accident, and just there's no bone. So the treatment plan was to place implant with simultaneous GBR, okay? And also I considered soft tissue grafting because of the marked recession. So this time I had to open, I didn't have really other choice because I did have to do massive GBR and all that. But yeah, so this is how it looked like. Notice I did papilla-based flap here and here and here. So according to the literature, when you do a papilla-based flap, compared to conventional flap that you kind of like incise through the papilla, this has a really fast healing and minimal scars and all that. Okay. So place the implant. Yeah. Lack of bone, exposed implant thread. So what I did for this case, I used a CTI membrane. So I really like CTI membrane in severely resorbed cases, because the key factor of GBR to be successful is that your graft material should not move, okay? But this really helps to hold your graft material in position. So it makes your graft material solid. With the collagen membrane and sutured. 2 weeks, not bad. So provisional RPD was delivered. 3 months post-operation. Yes. So for this case, so implant supported provisional crowns were also delivered. Well, this is a little different story, but I just wanted to show you this x-ray because if you remember the first case I showed you, I used cold cure acrylic, okay? I told you that the surface of the cold cure acrylic is very porous, and soft tissue doesn't like it. So instead, these days I use composite restoration, okay? So light cured, a dual cured composite. So this has much better surface, dense surface, so it's more favorable to the soft tissue. So there was a question of why socket shield? So Dr. Christopher Sim asked this question. So I think the question was about the third case that I showed you. So the reason why I use socket shield technique is because I believe that the socket shield technique best reserves your soft tissue or hard tissue profile, because you're not extracting the buccal part of the root. It's the most minimally invasive condition that you can imagine, right? So I did risk for that case a big deal because the patient already had periradicular ptosis. So what I did was I did section the root, and then I tried my best to surgically remove all those infected tissues. I did fail for number 22. If I were to do that case again, I think I'd probably do the same because I do have a backup plan. Okay, and you know, for number 12, it really worked out well. For 22, it was unfortunate that it had to fail, but even if it did fail, I didn't really do that aggressive of surgery to recover from that. So I don't think that I have lost that much trying that socket shield technique for that case. Okay. So this is how I created the emergence profile, made the impression. Hold on for a second. Okay, so there's a little bit of technical issues with my laptop. Just to talk about a little more about the socket shield technique, I did present some of my socket shield technique cases on my previous session, and it is very well described in the literature. And it does talk about the failure rate, the complications of the socket shield technique. One of the most common complication is the shield exposure, which means your root, the buccal part of the root, can be exposed in some of the cases. So the author tells you that you do need a backup plan if you're trying to do the socket shield technique. And the case that I just showed you, I think, for that case, for the particular case, the root wasn't exposed, but I did have like a secondary infection, so I had to find a way to kind of like deal with those kind of situations. So if you're not really confident about your backup plan, I wouldn't really recommend doing socket shield technique on any cases. If you feel that the patient has a really good anatomical situation without any infection, and for cases like fractured tooth, then you can try. But yeah, I mean, you always have to deal with, you know, the risks and all that. So, and it's on your own responsibility. So, I would consider all those factors and try some of the new techniques if you feel confident enough. Okay. Okay, we're back at the case. So for this particular case, implant supported screw retained PFZ crowns were fabricated and delivered, right? Not bad, huh? Well, I did have some of the, a little bit of loss of papilla, I would say, here, but big deal. Yeah. Okay, so Dr. Christopher Sim asked me another question. Long-term roots left buccally. So I think he was trying to ask me what are the long-term prognosis when using the technique, okay? Socket shield technique. Well, honestly, it's been only 3 years for me to use that technique. So I can just tell you about my own experience. Well, going back to my previous presentation, I showed one of my cases where with the CT scan of, I think, 2-year follow-up. So what happens is, so the buccal part of the root kind of gets, forgot the word, ankylosed with the bone. So it kind of like sticks into the bone, and then you can't really tell from the CT scan which part of the root, which part is the root and the buccal bone. So you can't really separate it on the CT scan. So you kind of like get ankylosed, I think. So I think, well, I don't really worry about the long-term prognosis after seeing that CT scan. But yeah, so far, I would say all the cases that I tried, I really didn't have any complications. All right, so this is before and after photo. Okay, so yeah, I think I am gonna have to wrap up my presentation. So yeah, let's jump to the conclusions. I didn't really have time for the last case, but yeah. So due to the anatomical limit of maxillary anterior area, ideal implant positioning for screw-retained prosthesis seems to be quite challenging in most cases. But we still strive to do that, right? Because I think for patient, no matter what it takes, because it's not in your mouth, but in patient's mouth, your patient's mouth for long term, and you want to give them the best option they could have, right? So thorough diagnosis of the case and various strategies are needed to restore challenging anterior implant cases. All right? So yeah, that's gonna be the end of my presentation. Thank you very much. To Christopher Sim again, would it be more predictable if you do without socket shield technique in the anterior area? Complication mean possible bone and soft tissue lost. Tends to, well, yeah, I do treat 100% Asian patients, and I agree that Asian patients, I don't know. Well, I don't know about that fact, but yeah, most of my patients tends to have very thin buccal bone. So that's the reason why I would try to use socket shield technique. Imagine the situation you're trying to extract maxillary central incisors when the patient have 0.3 millimeter of buccal bone thickness. You're gonna end up either breaking the buccal bone plate, or I don't know, it's going to resort for sure, 100%. So when you say predictability, right? So when you extract the tooth, what you can predict is that you're going to lose that bone no matter what when you have a thin bone. So what you have to do is you have to do GBR and soft tissue grafting. It's necessary, right? if you have a option to avoid that, then why not take that option? Okay, so that's my answer. Thank you very much.